And I'd like to introduce you to Martin Rogan. Martin is CEO of Mental Health Ireland, and he's going to talk to us about the requirement for recovery to be more than a romantic ambition. Looking forward to hearing this one. Now, Martin.
I suppose I'm the last of the romantics, maybe, in that way, you know. But, folks, just to say, it is an extraordinary coincidence that all these people happen to be in this room this afternoon. And I think the person you just heard, Catherine and Gina and the whole ARI team, have done an extraordinary task in networking and bringing people who haven't been here before. And that's an extraordinary achievement. So I think that needs to be acknowledged. So I'd like to congratulate the ARI team, if we can, to begin. So, we've heard a lot of conversation and we've heard a lot of talk about what is this concept of recovery, and there is a risk that this becomes some sort of a romantic, nice idea. But it has to be more than a nice idea, and it's not just, you know, a rare ambition, but it's something that we need to strive for. We're going to go through fairly quickly because I'm conscious people have had a nice lunch, they've had a great opportunity to network, and let's just explore some of these ideas. And you know, romantic ideas often start with a once upon a time. But the building we're in here, and in 1847, it became one of the large psychiatric hospitals, one of 22 across the country. And it was built, you know, at considerable expense, about £53,000 as it was at the time. In fact, there was a parliamentary inquiry, because in London there were complaints that there was too much spent on this hospital here. And I think to see it moved on and taken on a new role is really interesting. And the hospital was built actually for 3 groups of people. And they used the language of the time, and language is now considered offensive, but it was for 3 groups of people. They were for idiots, lunatics, and incurables. So I think we're all trespassing here today, because we don't fit any of those descriptions. Because nobody here is incurable, and nobody here is looking backwards. We're looking forwards, and I think that collective looking forward is what today is about. But bear in mind, in Ireland, in 1950, before people began to think of recovery in a practical way, the hospitals got bigger and bigger, to a point where we had 22,000 people. Over half of 1% of the population lived in mental hospitals at that time. And the expectation was that you would go in, but you weren't likely to recover and return. And it's only in the mid-1960s we began to see that happening in a much more commonplace way. People began to return to their communities and engage with life again, but sometimes in a constrained way. And I think what this exercise is about in ARI is say, let's look at, are those constraints necessary, required, or are they just limiting people when that's probably not necessary? Whole towns were dedicated to hospitals. I was almost run over on the motorway. When I saw this sign, I thought there was more to Ballinasloe than beds, but for many, many people, the town of Ballinasloe came to signify being hospitalised. And I think we need to look beyond that. There's a lot more going on there. There's a life there. And you know, that's really what this opportunity is about. But the question is, where does recovery happen? Does it happen in hospitals? Does it happen in day hospitals or clinics or community residences? And a piece of graffiti I saw in Dublin one day in St. Brendan's. On the wall, someone had scrawled "The Cure." Now, I think it was the band they were talking about. But some people sometimes confuse that. But certainly in the 1980s, when there was a big push with planning for the future to move forward and move away from the gravitational effect of large hospitals, sometimes there was a tendency to bring some of the habits and some of the traditions of the hospitals with us. And if you take something that's designed for healthcare and you try and create something else out of it, there will be certain constraints, there will be certain compromises. And oftentimes what was described then as rehabilitation was often simply relocation. The hospital was sometimes dismantled into smaller units rather than actually people fully rejoining with their communities. And if you recast some of those models that were really designed to be hospital elements, some of them didn't easily make their way fully into the community. And like anybody, if you stress a system, people are inclined to revert to type. So sometimes when you overload a system or you're not clear about what the path is, some health professionals were inclined to revert to type and find their way back into sometimes paternalistic roles, because that's what their training was often about. And that's why this program is so important. It brings together 3 really important viewpoints: the lived experience, the family member experience, and the professional, because we're working together. And you cannot take one element out of a tripod and change it without impacting on the other 2. So in working in tripartite, it's always much more effective. In Planning for the Future, which is November 1984, a long time ago, the language then was around rehabilitation. Vision for Change brought that language forward into recovery. And it actually used the term rehab and recovery in the title of its chapter. But I think more and more we're beginning to recognise there's more to recovery than just a next stage of rehabilitation. It's an outlook, it's a philosophy, it's an approach, it's a taking charge, and that's what's really, really powerful. Right, like in St. Mary's in Mayo, this signage here, and it shows recovery team is one way, community and continuing care is another way. And that's not to recognise that there are people who have very significant needs that perhaps will need some continuing care, but that should be absolutely in the most independent possible format that they would choose for themselves. And the whole message of co-production we heard so often here this morning is really key to this. It's a foundation stone. Without that, really you're going to limit your options into the future. So what is this recovery? And, is it rehabilitation, rebadged? No, it's a lot more. And I think certainly the fact that we're in a growing movement here is testament to that. People are really not even hungry for this, they're thirsty. It's much more immediate. Everybody wants to be on board with this. But is recovery about getting through the system and then airbrushing that away, not mentioning that episode in your life? I must get one of these woolly hats. So if you put the visor up, it looks like a helmet. If you pull it down, you say nothing. And most people who encounter mental health needs in Ireland will recover, will do well, but many will not mention the fact at a subsequent point in their lives. And oftentimes when we're talking about mental health, we talk about the 1 in 4 who will have mental health issues. As at a meeting in the States recently, they're talking about the 4 in 4. All of us will have an experience, all of us will have an opportunity. Research in the UK is saying in this year, 1 in 5 will be experiencing a mental health issue. So we're talking about us, not them, and I think the ARI project really captures that sense that we're working together, and it's actually probably silly to try and work any other way. But the question is, why is this not generally understood? Ben Franklin said, 3 people can keep a secret if 2 of them are dead. And why are we keeping this a secret? This is such an extraordinary, best-kept secret. It's a covert operation that people, when they have a mental health crisis and recover, tend not to go back and reflect and declare. And is there an expectation that we'd expect people to do that? But it does leave a public perception, and public perception is really important here, that when people develop a mental health issue, that somehow their life is paused or constrained. That's not the case. The vast majority of people do really, really well, and others are moving at a different pace, but getting towards wellness. So why do we keep this a secret? And if you had tuberculosis, would you keep it a secret? Well, for many years in Ireland, if you had tuberculosis, you would keep it a secret because it had a poor outcome. Equally in the past, if you had HIV, treatment options were quite limited and the outcomes weren't great, and it was often heavily stigmatized as a result. In mental health issues, we need to move beyond the secrecy and sometimes things that drive stigma, because it does limit people's ability to access service and the time at which they would access service. The word stigma in translation means an outward sign, and what's interesting, in the mental health environment, people don't carry a sign or a limitation in some way. You might see Paddy wearing a sling today, but that's the only thing that denotes he's injured himself. And he'll tell you about it. In fact, he won't stop telling you about it. He's shy like that. But in terms of, there does need to be a new articulation, and it needs to be a more confident, upbeat and positive message, not one of limitations and disability, but also about opportunity and moving forward. And sometimes the language in the past has been around hopelessness, and it's often been around that sense of failure, a perceived weakness, some embarrassment, that you wouldn't mention this, you wouldn't talk to anyone about this. I think we need to get past that. And I think increasingly over the last number of years in Ireland there's been a grand awakening to the point where it's almost impossible to service the demand for information, guidance and advice. And we can see many extraordinary agencies here working in this space, encouraging people to mobilise and get together. But oftentimes the experience has been about being removed and isolated and separated. Before psychiatrists were known as psychiatrists, they were called alienists. And the idea was that this was a person you would go to if you felt alienated, either from your community, your family, or indeed from yourself. So we need to move past alienation. And there's 200 people here in this room, and there's been 300 in Kilkenny, and there's more opportunities coming as well. to see that we're not travelling singly on our own here. But recovery is also about taking back responsibility and moving back into the mainstream of traffic. If you've had a difficulty in your car, you pull over into the breakdown lane, you fix the puncture, you see what's going on, what that strange knocking noise under the bonnet is, but you go forward and you get back into the mainstream of traffic, and that means getting back into college, into work, into your life. And as Marina talked about this morning, hugely important things like housing and IPS type projects are really important about regaining your foothold and having a life, which doesn't mean that mental health issues are behind you entirely, but they don't dominate and take over your whole life. When we ask ourselves about, well, how does this fit in terms of, we talk about clinical recovery, we talk about personal recovery, and I think Marina described this really well. You know, they're not diametrically opposed, and sometimes we have a conceptual model that says treatment is over here and recovery is somewhere else. They are along a continuum. So it's not straightforward treatment equals recovery, or that treatment works against recovery, or treatment versus recovery. These are unhelpful snap decisions, and I think we need to have a more rounded understanding. And I think that's why this opportunity and this initiative is so important in this. So the question is, when we think of the word recovery, it tends to conjure up nice, warm, fuzzy feelings. And sometimes this does tend to romanticism at times. Stuff that is universally popular, like motherhood and apple pie, and freedom and health and wellness, all these lovely, effusive type of terms. But the question is that the case for everybody? Are there people who, for lots of reasons, sometimes structural reasons, sometimes related to benefits, sometimes related to treatment, sometimes related to life roles, where the concept of recovery is quite a frightening prospect? It's a huge step forward. It's stepping out of your comfort zone. It's moving into a new space. It's about taking back responsibilities that might have been removed from you at some stage. So is recovery a universal or popular concept? And to get into workshops, this is an area you might want to explore. Is everybody ready for recovery? And is it moving at a pace that's comfortable and appropriate for everybody? Do people feel sufficiently supported? And that's why skills and tools and learning and networking here are absolutely vital to this process. My eldest son is an engineer. He's working in Finland, and we were over to visit a few weeks ago, and we saw a guy on one of these recliner bikes. And I said, that looks like a really smart way to ride a bike. Less wind resistance, look quite comfortable. Why aren't all bikes that way? And Dara, who's an engineer, said, well, if that was the easier way to have a bike, all bikes would be that way. But bikes are often quite different. And sometimes what we're used to, we just follow on with and roll it forward and make little incremental adjustments. Sometimes you need to make a great leap forward. So this is what I'm calling, when it comes to recovery, it's the Tom Jones factor. It's not unusual. And I won't break into song, you'll be glad to hear now, because most of us are squeamish. But is recovery the exception, or is recovery more likely than not? And I'd be interested in your thoughts on that in workshops later as well. The question is, if I have recovered, am I unique? And this is what we call exceptionalism. Am I the lucky one? I'm just the one who happened to get it together, I happened to get good supports, good family supports, good treatment options, and sufficiently resilient to claw it back and get back together again. And we won't call this one the Tom Jones effect, we'll call this one the Late Late Show effect. And the question is there one for everyone in the audience? Is every member of the audience, every person who has significant and sometimes very distressing and often disabling mental health issues, is there recovery for everybody? And how do we understand that? Or am I just the lucky guy who managed to escape? And that's why initiatives like ARI are so vital. They're around making contact, making connection. When you're in that setting, when somebody asks the question that you were afraid to ask or uncomfortable to ask, or it might have been unpopular to ask, you're in a safe space here, a collective space where people support each other and work together. And that kind of reaching out and connection is so important. Probably one of the best documents I've ever encountered is a piece of research done by UCD and Sheridan there, and it was around enabling recovery. And it looked at, well, human connection, having a relationship. And they basically discovered that if you had 3 friends who weren't either using the mental health service or a staff member of the service, you could have your readmission rate, because it meant you were connected, you were part of a wider community and you're active in that space. It's called Enabling Recovery. You can get it online, it's hard to get in print. But can you go solo? Can you just say, listen, I've got my recovery, I'm out of here, thank you very much, I've got what I needed? Or is it broader than that? And as in the States recently, I saw the sign on a homeless shelter. It basically said that none of us are home, but all of us are home. So there is a shared collective responsibility, but it's balanced around recognising the individual. Because a huge part of what we understand as recovery is individualism. Marina described earlier being in a room with 20 people. Michael said I was in a room with 3 people. Recovery actually begins in a room with one person. And the person looking at their circumstance, what they've learned from their experiences, what they can mobilise and how they can gather that. This was a Where's Wally world record attempt in Merrion Square in Dublin. My son and his wife are somewhere in there, they're wearing a red and white top, and you see they're wearing a kind of woolly hat as well. Easy to spot. But we always have to understand and recognise that people are moving at a different pace. People are at different levels of realisation, comfort and courage. And individuality, uniqueness, and the independence that goes with that must be respected at all stages. And that's what I like about the ARI model. It's scalable and it moves at the pace that fits the individual. That is vital. Marina touched on this morning in terms of many people describe the experience of using services as being fixed, almost like a passive experience, and that somehow they're being changed in a way that necessarily wouldn't be of their first choice. I think we need to get to a more rounded view. It's not simply about symptom control and being discharged back to community services or back to primary care. It's about regaining the personal locus of control. I'm in charge of my life, I make decisions. They're probably not always great decisions, but they're my decisions and I live with the consequence and I manage that piece. And it's kind of the distance between moving between suffering and surfing. That you don't get to control everything, but you try and manage the environment as it comes towards you. And I think in the whole concept of recovery, it is around writing your own life script. That you invent yourself. And it may not necessarily mean going back to the person you previously were, but you now have new skills, new experience, new insights that maybe others don't have. I think in the recovery environment as well, we found many, many people, and Marina described this and Michael described this morning as well, we find people have been cast in roles that aren't necessarily a good fit. And sometimes they are asked to wear uniforms that don't fit them terribly well. So this cartoon shows zebras being painted in the morning before the tourists arrive and saying, you weren't supposed to see this. So sometimes being introduced as a consumer or a family member or as a professional creates an expectation that you're going to behave in certain ways. And that may not necessarily fit your style or be entirely comfortable for you. We mentioned briefly too the whole concept of public understanding, because people have an expectation of mental health services, and sometimes that's quite a paternalistic view. This day last week in Dublin Castle, Sean O'Farrell, the Count Corley, Dáil Éireann, invited senators and ministers and TDs to an event, and there were about 200 people at this. And it was held in one of the spaces in Dublin Castle, and the signage was quite interesting for this. It was a parliamentary symposium, but next door to it was the Garda inquiry, called the Disclosures Tribunal. And I wasn't always sure which of these rooms I should be in, because having recovered or having had a mental health need, does that now require you to go out in a public space and introduce yourself as such? Or can you just rejoin the traffic and carry on? And I think we've seen this a lot in media, we've seen it with celebrities, we've seen it with sports stars, and sometimes it's helpful in moving the conversation forward, but there has to be a more rounded view, that I'm back as myself, having had certain experiences, but I'm rejoining the traffic and I'm going to go forward. One of the things that irks me a little is when you read in the media, and the media have a big role to play here, but they describe people admitting to having a mental health issue, as opposed to sharing that they have a mental health issue, or describing their depression, or whatever. But the language is still around admission, as if there's some fault or some blame attaching there. So every time I talk to a journalist, we try and move them forward off that. 2 minutes. And if you want to see Captain Rogan really angry, I'll go on for 3. Okay? One of the things we need to be mindful in this space is that people can over-identify with labels. And the label, be it as a professional, as a family member support, or a person with lived experience. And in diagnostic terms, people are inclined to draw a little triangle in medical notes when they want to describe a diagnosis. And we're conscious of the concept of thinking outside of the box, but we also have to think outside of the triangle. because there's more to the person than their diagnosis. They have a whole cosmos of opportunities, a whole range of possibilities that we don't know about. This is far too limiting when we consider people in diagnostic terms. It's undermining and ultimately can be quite degrading. When I was in the airport coming back from States there a few weeks ago, I saw this sign here. And basically, this airport was in a place that's prone to hurricanes, and there's an area, if it's a hurricane, you should go into this so you'd be safe, so there wasn't flying glass and whatever. But it was an area of rescue assistance. And I think in this whole space, it's about moving the conversation forward from dependence, independence, and interdependence. And this is just not for people who use services or access services, but also for professionals. Many people had a dependence on being the helper, being the rescuer, and these are roles that can be quite limiting and actually aren't as widely demonstrated as they really should be. So I think, is there actually a stigma around recovery? Because this is the piece we don't talk about. This is the piece that is lacking its profile. This is the piece that people aren't discussing in a much more open way. And I think organisations and opportunities like ARI create a space to have a different dialogue, a different conversation that's more hopeful, more encouraging, and looking to the future. Recovery is a movement. Now this graphic here is a bit odd. If you find you're looking at it and they seem to be moving, but they're not moving. And I think in one of the workshops earlier, we were saying that in 2008 there was great movement in County Mayo, for example. It progressed really quickly, went forward, and then it paused, and probably got a little bit lost, and probably had to reflect for a short while before moving on to the next stage. And in any movement, you need to make sure you're bringing everybody along with you. People with lived experience, family members, professionals, and indeed the public, so that there's a new understanding that we go forward with. And sometimes in making change, we're inclined to reject and cast out everything that went ahead as if it was harmful or unhelpful. I was looking for a yellow sticky in my office the other day, and I found this one. And it basically said, stick with the professionals. And I think in ARI and in the movement around peers, we've looked beyond the professionals. We're not excluding, we're including and actively bringing everybody forward. But it's not just sticking with one old model, because I think we do have to look at new opportunities. But when you're bringing change, you have to recognise that this can be threatening for people. This can discommode other people. And in a complex system, you can't easily do change. You can perturb the system, but it'll find its new equilibrium. So this is a Newton's cradle, and when you pull out the counters on one side, displaces the one on the opposite. So when you're working with complex systems and you're introducing change and movement, don't be surprised that systems can recoil, can react, and come back, can pull back from that. 2 more slides. When the whole area of peer advocates is coming over the horizon, myself and Catherine did quite a bit of work in this area in the past, worked with DCU, worked with Irish Advocacy Network, worked with a range of different agencies. A staff member who was a bit cautious of this said, what exactly do you mean by a peer? So I sent him back a text. It was late on a Saturday night, and I was probably getting a little bit impatient at this stage, because we'd had long and many conversations about this. So when he asked what exactly is a peer, I took a very literal translation. So a peer can be a member of the House of Lords, to stare intently, to support a gate, to share a common experience, a point of embarkation, as if you're going on a ship, or a fellow traveller. And I think the people you've met here are peers. And irregardless of the path they've come, they share many of the attributes that are going to be absolutely critical to the recovery movement. So while I was being a little bit pedantic, there's actually some truth in what is a peer. And I think in the future we're going to see peer workers in different contexts and different opportunities bringing unique insights and very particular perspectives that are going to be really important to us. And I suppose one of the questions and maybe a challenge for today is whose responsibility is it to convert non-believers? Because not everyone is enthusiastic on this topic. Not everyone shares this viewpoint just yet. And this is why the recovery framework is going to be so important. A lot of care and a lot of time has been taken to make sure that everybody has a shared understanding so that the language means something to all of us. And that's why I'm really encouraged and very happy to be here today. Thank you.